Hello, good morning, everyone, and welcome to this series of the CARPHA Health Rounds webinars. And today we are raising the bar. Today we are raising the bar with CARPHA guidelines on the management of diabetes in primary care and also the COVID Module 5 systems for monitoring. Thank you for joining us. We would like to bring your attention to a few of the features of our Zoom webinar interface. This morning, you will see at the bottom of your screen, you will see some icons for chat and also for Q&A. This morning, we'll be using the Q&A for questions related to the content of the webinar, the technical questions, and the chat. We're asking you to pose questions, any other questions in the chat. For example, if you would have access to recording, that would be the type of question we'd like you to pose in the chat. This webinar is being recorded. Right, and now I turn you over to Ms. Abby Elegon, our moderator for today's session.
Hello, good morning, good afternoon, wherever you are. Welcome again, everyone, to the final installment of the CARPHA webinar series, Raising the Bar, CARPHA Guidelines on the Management of Diabetes in Primary Care and COVID-19. So this series is supported by the Agence Française de Développement, AFD, or in English, the French Development Agency. And this is one element of their support for CARPHA's non-communicable diseases program. Today's webinar is also made possible through our collaboration with the Caribbean College of Family Physicians, the CCFP. So the CARPHA guidelines was updated in 2019 in collaboration with the Secretariat for the Organization of Eastern Caribbean States, the OECS, through funding by the World Diabetes Foundation. These guidelines were updated with the aim of strengthening the management of diabetes in primary care and thus improving health outcomes for persons at risk for and those living with diabetes in the Caribbean region. The guidelines take a modular approach, which this webinar series has also followed. Module 1, as you may recall, focuses on evidence-based treatment protocols and algorithms. Module 2 covered healthy lifestyle counseling. Module 3 provided guidance for persons with diabetes and their caregivers. And Module 4 outlined information of essential classes of medicine available for the care of diabetes. Recordings of these 4 previous webinars in the series are available for viewing on the CARPHA Campus YouTube channel. We will share that that account in the chat for your easy reference. So this webinar will explore the 5th and final module of the guidelines, Systems for Monitoring. And this looks at the implementation of the guidelines using standardized indicators and tools. We will also provide an update on diabetes clinical management and COVID-19 infection. So today we will hear from our very own Dr. Tamu Davidson. But before we begin, I would like to invite all of our attendees to participate in a short survey, which should pop up in your screen in a bit, and you can scroll down to see all 7 questions. Your responses to these 7 questions will help us get an understanding of your existing knowledge and practice. We will allow 5 minutes for completion, during which we will review our feedback mechanisms and introduce our presenter. Please note that we will also have a post-presentation evaluation of similar length. So again, we invite you to take this poll. It should have popped up on your screen. If not, do put in the chat and let us know if you are having issues. You can scroll down to each of the 7 questions and select your response accordingly. So as a refresher of what our IT personnel would have shared with you, participants are asked to place any questions for our presenter in the Q&A section using the appropriate icon on your screen. These questions and concerns will be addressed during our Q&A session. Any other questions or comments can be shared with our webinar team via the chat section. I'd like to ask for the introduction slide for Dr. Davidson while our participants are doing their poll, please. And again, these are easy questions, so I'm assuming everyone will quickly go through them. So again, about our presenter, Dr. Tamu Davidson. She is the head of chronic disease and injury department at the Caribbean Public Health Agency, CARPHA. And before joining CARPHA, Dr. Davidson worked as a general practitioner and public health specialist for a combined 24 years, working in both urban and rural Jamaica at every level of the health system. In that capacity, Dr. Davidson has led programs to improve the standard of care for persons with non-communicable diseases, including the monitoring and evaluation of these programs in Jamaica. She is also a past lecturer in epidemiology and non-communicable diseases at the School of Public Health and Health Technology, University of Technology, Jamaica. I'd like to apologize if you hear any noise in my background, but I hope that you've been able to hear me. So I think we have a couple more minutes in terms of persons who may wish to complete that poll before we ask our presenter to start her presentation. And I hope everyone is excited to hear this presentation. Monitoring and evaluation in particular is a passion of mine, and I am definitely looking forward to hearing Dr. Davidson speak about how we can best monitor and evaluate how we use and implement the guidelines on diabetes for the Caribbean region. So at this point, I'd like to ask Dr. Davidson to please go ahead and give us our presentation. Thank you.
Okay, thank you. I'll now share my screen. Give me a moment, please. Good morning, everyone. Welcome to another CARPHA Health Round. I will be presenting today on the final installment and module for the CARPHA guidelines for the management of diabetes in primary care in the Caribbean. So this morning, we will just highlight some of the guideline, some of what was done before and mentioned by our presenter. But just to give you an overview of what this presentation will entail, we'll look at the background around the guidelines and how it was developed. We'll look at some key definitions. We'll look at monitoring system, and we'll look at supervision and clinical audit, and then some key take-home points for this guideline presentation. So just to give us some background, the Caribbean and the world agreed to and committed to these two key targets for non-communicable diseases. And these really were to really reduce premature mortality from diabetes by 20%, 25% by 2025, and the Sustainable Development Goal to reduce by a third diabetes premature mortality by 2030. And this is because we know, and it has been recognized, that NCDs, including diabetes, is a development and health problem that is impacting the entire world, and most importantly, the Caribbean, and is leading cause of death for the region. And so in order to really reduce premature mortality, one key ingredient and one key step is really to improve care, the standard of care of persons who already have diabetes. So to improve their care to reduce their early death and mortality from the disease. And also through the standard of care to be able to detect early persons who may be at risk for diabetes. So this is a key strategy this guideline towards reducing premature mortality in the region. And just to say that these targets translate to reducing premature mortality by an estimated 2% per year in our member states. So what about diabetes guidelines in the Caribbean? So there were previous versions of guidelines produced by CAREC, the institution that followed that was previously in place before CARPHA. And these guidelines were produced in 1995, 1998, and 2006. So we have had guidelines for many, many years in the Caribbean, and specifically the guidelines were called then Managing Diabetes Primary Care in the Caribbean. In 2004, we also had the protocol for the nutritional management of obesity, diabetes, and hypertension in the Caribbean. And that was produced by the former institution, the Caribbean Food and Nutrition Institute. So the CARPHA guidelines were developed in collaboration, as mentioned by our host and moderator today, the OECS, funded by WDF, and based on the WHO, HEARTS, and WHO's package of essential NCD interventions. These guidelines were launched in 2019. So the aim of the CARPHA guidelines for the management of diabetes in primary care in the Caribbean is to improve the quality of care provided to persons with diabetes across its member states. And if you recall the earlier slide, and this is towards reducing premature mortality due to diabetes and its complications. So the guideline itself takes a modular approach. And as our moderator mentioned, we have covered 4 of the modules so far. And this is the final module, which looks at systems for monitoring. And so this is the final, but also critical guideline that we need to be aware of and sensitized to. So the aim of Module 5, really, this module is intended for use by managers at various levels within the health sector involved in health systems evaluation. And this should be used both at the national, subnational, and facility level. So this module is intended for that use, and of course, adaptation to your country context in your specific country within the Caribbean. So staff also who are involved in collecting and collating data, planning and managing and monitoring systems for the management of services in primary care is also one of the target groups for this particular guideline. So the guideline highlights a plan for monitoring and evaluating with appropriate indicators, including quality-oriented indicators of the implementation of the guideline. It provides some potential indicators with some standard definitions that can be adapted or adopted to the local country context to monitor implementation. Just to mention as well, the guidelines, the 5 modules, including this, can also be used to update existing guidelines which countries may have for their diabetes management. So how is this guideline structured? So here in the table of contents, we have the introduction, which goes through the use of the model, how you choose indicators. It also takes you through levels of monitoring, models of record keeping. It gives you the indicators that are recommended, some core set of indicators for the guideline. Then it has a section which looks at the data collection and reporting tools. And then we have a section that looks at analyzing and reviewing data. And so this is the essential content of this particular guideline and module in terms of guidance. And we do have some tools here that can be adopted and adapted as required. So at this time, we'll cover some basic definitions. And so just to ensure, these are some 3 key definitions that I find very important to share so that we ensure that these are some of the questions we usually get when we're talking about systems monitoring. So what is monitoring? So monitoring is the ongoing collection, management, and use of information to assess whether an activity or program is proceeding according to plan and or achieving the defined target. It involves the collection of routine data that measures this progress towards achieving program objectives. And so this was one of your poll questions that we're giving you today. And so there's several, you'll see varied definitions of monitoring, but this is the key definition that we'd like to share with you today. So what is evaluation? So evaluation essentially is the periodic analysis of a program's progress toward meeting established goals and objectives. So for example, you may do an evaluation at the very end of your program, which is 2 years, or if your program, which is continuous, you may decide to do an evaluation annually after 2 years, after 5 years. So it's really a periodic analysis of where the program is in terms of meeting these goals and objectives. The next definition I like for you to be aware of is what is an indicator, because we'll be using that term throughout the presentation a lot. Essentially, it's a measurement that reflects a given situation. So a specific observable and measurable characteristic that can be used to show changes or progress a program is making towards achieving a specific outcome. So we share more in the presentation, later in presentation, some of the key indicators. And so selecting indicators is a critical component. So this covers some of the basic definitions that I'd like to share, I wanted to share with you. As we go through the presentation, these terms will be utilized. So let us look at the monitoring system. As we mentioned earlier, this particular guideline focuses on systems monitoring and some of the key things, indicators that will need to be selected. So at the heart of monitoring a system are the indicators, and indicators are the foundation of this monitoring system. So one of the things that you need to do in monitoring the guideline is selecting indicators. So identification of a core set of indicators for measuring performance and monitoring the implementation of the guidelines. These indicators should be standardized so that they can be used for comparison over time and across places and populations. So in the guideline, we give you a recommended list of indicators, core set that can be used for monitoring and implementation of the CARPHA guidelines for the management of diabetes in primary care. So the core set of indicators, one group looks at health service coverage. So for non-communicable diseases, the key indicators include number of patients with diabetes registered, the proportion of clients with type 2 diabetes documented, control within 1 year post-guideline implementation. Then it looks at the proportion of clients with hypertension as well, documented control within 1 year post-guideline implementation. So really this tells you how well you're doing. It will give us a sense of the quality of care with respect to individuals being treated. We look at the percentage of individuals diagnosed with type 2 diabetes and being treated according to CARPHA diabetes guidelines, percentage of clients with diabetes who have received healthy lifestyle counseling in the last 12 months. Some of these indicators can be adapted to your setting. For example, percentage of individuals diagnosed with type 2 diabetes and being treated according to the national guidelines. That may be a way that you could adapt that particular indicator. The next group of indicators looks at screening and preventative care under the broad heading of health service coverage. So this looks at percentage of individuals greater than or equal to 18 years screening for diabetes according to CARPHA diabetes guidelines. And then it looks also at the number of clients with type 2 diabetes who have been screened for diabetes related complications according to protocols. So this looks really at the delivery of care and how this care is being delivered to persons against a standard, and the standard here is the CARPHA diabetes guidelines. And certainly in your own context, you can adapt these indicators to look at the standard with respect to your own national guidelines. The second set of indicators here looks at access. And so access, essential medicines, so the availability of core diabetes medicines and the availability of core cardiovascular disease medicines. So those are other indicators that are included as a part of the health service coverage. So here in the guidelines as well, for each indicator, we have what we call the indicator reference sheet or metadata. And for each indicator, it provides you with the name of the indicator. And I've cited an example here, and this one is looking at hypertension control within a year post guideline implementation. So if you recall earlier, I mentioned some of the NCD indicators with respect to health service coverage. It looks at the indicators benchmark. So a fixed target as per local context. So for the benchmark, the target, that would have to be developed based on the local context. And so most importantly, it'd be good to have a baseline for this particular target. As you begin to introduce this indicator, you'll need to look at the baseline and then set the targets based on the local context. It looks at the domain. Here is health status. The subdomain, it's a quality indicator. And then it looks at the rationale and purpose to measure the effectiveness of clinical services in the program to control blood pressure among cohorts of treated patients with diabetes. Then it goes on to give you the definition of the indicator. So percentage of patients registered for diabetes treatment at the health facility whose blood pressure is controlled 6 months after treatment initiation. It moves on then in this indicator reference sheet to give you the numerator. So what is in the numerator? And here for this indicator, number of patients with diabetes who have recorded controlled blood pressure at the last clinical visit in the most recent quarter, just before the reporting quarter. So these indicators are typically reported on a quarterly basis. Then there's a denominator, the number of patients registered for treatment of diabetes during the quarter that ended 6 months previously. And then it's a percentage, multiplier is 100. And then the data type presentation presented as a percentage and disaggregation. So here, this data could also be disaggregated by sex, age, and gender as well. So by sex and age, sorry. So it also then having the numerator and denominator method of measurement. So how are you going to measure it? How are you going to get this data? So this can be measured through facility audits, clinical audits that are done. It can also be measured through reports that are submitted. So key through your administrative database within your health facility. Key data elements that would need to be considered and captured would be the date of registration, date of last visit, last blood pressure recording in the last 6 months. So later on in the presentation, we'll look at some of the data collection tools in order to provide you with some of the information for these indicators. Then it looks at measurement frequency, and then from a monitoring evaluation framework perspective, it's an outcome indicator. It looks at data sources. This would be the health facility register for diabetes. And then it could be also your electronic health records the patient files, laboratory databases. These are other sources for getting the information with respect to the numerator and also the denominator for the indicator. And the indicator source would be the health facility of the respective Ministry of Health. And if you cover private facilities, that is where that data would come from. So this is just an example of reference sheets that are available for all the indicators mentioned in the guideline itself. But if you are creating and developing other additional indicators that may be of national importance, then we should have this type of layout and reference sheet so that persons understand what the indicator is, how to calculate this indicator, what are some of the sources of data for the indicator, and this, so that we're all reporting on the same indicator in a standardized way. So with respect to having selected your indicators, with respect to monitoring of the health system for the delivery or the implementation of this guideline, this monitoring should happen at 3 levels: at the health facility level, at the district, regional, subnational level, and at the national level. And these levels should be working together to monitor the implementation of the guidelines for diabetes. And from the health facility level, the data is in fact passed up. And you will have different monitoring by management, by the healthcare team with respect to each level. But each level should be doing their own monitoring, but working together and collaborating to do this. So what are the ways, the sources of data, record keeping that may be in your particular facility, or the ways you could store that data? So there may be a paper-based system to collect this information at the health facility on the implementation of the guideline. There may be a hybrid paper and electronic system. So there may be paper system at the health facility or electronic system at the health facility, or both, and at each of the levels, at the subnational level and at the national level. And there's the electronic record system. So for example, you may be collecting this information in a paper-based system through your paper-based files, clinical records of patients. You may be collating the data on a standard reporting tool. This information may be passed up to the district level, where at that level, the health department may enter this information into an electronic system at that point in time, which is then sent up to a national level. And that is just an example of how this record keeping may have been done. So what are some of the data collection and reporting tools provided as guidance in the guideline? So with respect to the health facility level, one of the tools may be the treatment card, or in your setting, it may be called the patient medical records. And this tool captures data from the management of an individual patient being registered in the system. So from the first interface of that particular patient with that health facility. So each patient assessed and managed for diabetes, hypertension, or cholesterol should have an individual record in which information is recorded at every follow-up visit. So in some settings, this already may be electronic health record system that captures that information. So it may be fully at that point of care, an electronic system, or it may be a paper system where you are registered, or it's just the demographic data, basic data that's inputted into the electronic record, and that's printed, and everything else then is now paper-based with respect to the client. So some of the advantages of this is it highlights key diabetes-related information that a healthcare worker should review and record at each visit, facilitates comparison of key clinical information, and can serve as a clinical reminder for important aspects of care, can be used as a basis for supervision, and serves as a primary source for the data for minimum indicators. So it's important that at this facility level, that this medical records captures some key information about the clinical interface and assessment of your patient. And that may be done through a standardized form, which you may already have existing in your health facility for a paper-based system, or for a system which is an electronic medical record system. So also at the health facility level, there may be for data capture facility registers. So you may have a specific register that's for chronic diseases, a specific register for diabetes alone, standalone, or for diabetes and hypertension that collects key critical information that can track patient care, and also that data can be extracted, utilized to track or report on your indicators. So a patient register to which the selected patient data is extracted from the individual patient treatment card or medical record, and that data from that individual patient is entered into the register once the patient interfaces with the health system. So if the patient is started on treatment as indicated, the treated patient is then transferred out, lost to follow-up, or dies. This information can also be tracked in the facility register. At the facility register with a visit, routine visit, you can also track parameters such as the blood glucose level, blood pressure, certain checks that the patient may need to do annually and routinely. And so this information can be found in a register. So the facility register provides the health facility with a quick way of assessing the number of patients registered in the system, and it can be stratified by gender and age. It allows a quick assessment. So this is the facility register is something that you can review on a weekly, quarterly, monthly basis to see how your patients are doing in terms of meeting their targets and goals for management, and how they're doing in terms of with respect to the standard of care that has been set. So each quarter, the number of the cumulative persons who have been transferred, lost to follow-up, who have died, enabling health facility staff to check on their reports and preparation. So you can get that information to look at your patients. It's also a good tool to also help to send out reminders to patients to look at who is lost to follow-up, so you can do follow-up to get them back into the system and into care. So it's useful to maintain an outpatient register to fill in brief information. So the key information would be the name, the ID number, date of visit, diabetic status, hypertension status, the fasting blood glucose, and or HbA1c. We can use the systolic blood pressure over the diastolic blood pressure, which is blood pressure reading can be tracked. And this can be compared to the patient card during clinical audits and regular compilation of indicators. So a facility register is a key tool that can be used to really understand at a quick glance what is happening with the patient, and also a key tool to extract information to report on the indicators mentioned earlier. So at the health facility level, in terms of reporting, reporting is recommended quarterly reporting for this type of data. This data is really not required on a monthly basis. So the data for quarterly reporting is compiled using the patient treatment card or the medical record, as well as the patient register, that facility register that you may have specifically for diabetes or persons with chronic diseases or NCDs. So the register can be used to calculate the denominators. Some of the indicators, the treatment card may be needed to calculate the numerators. As the cumulative number of patients in the clinic increases, then this task may become more time consuming if we're relying on paper-based system. And so ideally moving to electronic records system would be considerably easier for that task. So, however, the best system is the system that is easily adaptable in your context and you're able to utilize in your context. But as the indicators increase, it is better to have this on an electronic record system. And so ideally, electronic medical record system being available at your facility, which may not be in many, many places, would be an ideal situation in terms of trying to ensure that you have this information captured, reporting on this information, and analyzing this data. However, in many instances, in many settings, the electronic record system is not available, but a paper-based system can also do the same. So in terms of reviewing this information, you want to review of the aggregate patient data occurs at a regular interval. So you may want to do this every quarterly. Some countries, they have quarterly management meetings where they can share this report that's generated and look at how they're doing based on the report and data that's generated from these health facilities. So these quarterly reports focus on the agreed minimum set of indicators that are used to monitor progress of the program. Supervision and audits are also carried out at set intervals to ensure that the guidelines and processes are being followed. And we'll speak about the audit shortly. At the subnational level report, data here, the data that's collated at the health facility level is now reported up to the subnational level. And at this stage, this review would include the review of aggregate patient data from all the facilities in the district, and that should occur at regular intervals, typically quarterly. However, if you're at a health facility, you probably want to do this on a monthly basis to ensure that by the time you actually get to the end of that quarter, your data, you would have accounted for any issues in your data, and you'd ensure that the quality is maintained or issues are addressed early. So this enables district performance to be assessed and comparisons to be made between health facilities in the district. Challenges encountered during the facility-based supervision visits, referring to use of supervision audit tools, can be discussed at the district quarterly meetings. So I recall many of the district quarterly meetings that I attended and also presented at many years ago when I was working as a district medical officer. This is a very good opportunity for really bringing the team together to really look at the data, look at what the data is saying, how we're doing with respect to our targets, and to really be putting in interventions early to address the gaps that have been identified. But it's also an opportunity to acknowledge success and to look at some of the best practices that can be shared amongst the team and amongst the health district. So that highlights the key reporting of data reports that would be generated from your health facility in terms of monitoring what is happening with respect to the delivery of care implemented in your setting. Again, part of this systems monitoring that will also contribute to these reports is the supervision and clinical audit. I can't overemphasize how important this section is. This is typically led by the doctor who is working at the health facility, or the medical doctor in the health district there, the public health doctor who may be in charge, or the medical doctor who's working, district medical officer. There are different names in different islands. And this is done as a team approach, supported by the nurse who may be at that health facility, and also other health professionals that are involved in different aspects of care. For example, the nutritionist, dietitian, the pharmacist. It may also include, so this would be the core team. What's important for the clinical audit is that, of course, it's important to maintain confidentiality, and only those who are allowed in your specific country by law or by the policy in place that to access patient information are usually ones who are involved in the clinical audit. Because of course we must maintain confidentiality at all times, and this involves reviewing patients' records. So you'll see that the medical doctor in this case would lead this process in reviewing the items. So you want to ensure that court supervision is built into any plan that you have, and supervision is ongoing, should be a continuous process, and supervision would be at all the three levels mentioned earlier. So for this section of the presentation, we'll be going through what is provided, information that's provided in the guidelines with respect to the clinical audit component. So clinical audit really involves measuring a clinical outcome or a process against well-defined standards of care. And you really want to be doing this clinical audit at least quarterly, so that within your context area and at the health facility. And so it's important to really assess what is happening with respect to care. So the clinical audit really enables the extraction of data from a random sample of patient records to measure the minimum indicators for quality of care and health outcomes. It's also used as a supervision tool to review a limited number of records for data quality, which looks at completeness and coherence with the register, as well as quality of care. It's also used to review a limited number of records as part of the internal facility and quality management process. So in doing the clinical audit, there are set inclusion criteria and exclusion criteria. So those who would be records that you would be auditing would have to have a diagnosis of diabetes, have had at least one visit to any of the clinics offered at the primary care facility during the audit period. Those that should be excluded from the audit of that facility would be those who receive the majority of their primary care during the audit period outside of your facility, then have died before the end of the audit period, have pre-diabetes or impaired glucose tolerance only. So those would not be included in the clinical audit for diabetes. And finally, have moved permanently or temporarily. And so this is why the importance of having the register to be able to have that and track that information easily. So when carrying out the clinical audit, one of the things you'll have to determine is the sample size. And so in the guidelines itself, it provides us on pages 51 to 52 with a lovely table and template for you so that you can determine the sample size. It also provides you with some background as to how to calculate it. So if we look at the population eligible of eligible patients, so for example, let's look at 50. You can tells you whether you want 90% certainty within 10%, and this is the one that we recommend. You would need to do an audit on 29 patients. So it goes along depending on the confidence intervals and level of certainty that you would like. It tells you exactly how many patients that you should have for your sample size. So how do we then go on now to select the medical record or chart? So this should be a systematic random sampling technique to select the medical record or chart. Step one, what we do would be to prepare a list of the patients with diabetes from the primary care facility that meets the inclusion and exclusion criteria. So that list could probably be, you could probably get that list from your medical records team at that health facility to provide you with that information. Then, and you will look at the list over the reporting period. And then step 2, you determine the sample size. And here we have assisted you in the guidelines by providing you with a table to do that. But there's also information there as to how to do that from scratch if you do not want to use the table itself. Step 3, then you would divide the number of patients on the list from step 1 above by the sample size determined in step 2 to determine the sample interval called K. Then you randomly select the first chart to audit from the first K records, and then you select every K chart after that one on the list. So I'll provide you with an example for this. And this is also in your guideline as well. So suppose you need to select 69 charts from a list of 1,000 eligible patients with diabetes. You would divide 1,000 by 69, and so you get approximately 14 for K. You must then select one chart out of every 14. So you use any method of random chance to determine which of the first 14 patients on the list should be selected. So you could number 14 pieces of paper with 1 through 14 and have someone draw one. If the number is 5, then you select the 5th patient on the list, and then every 14th patient after that, so 19, 33, 47, etc., you would select for the audit. You then pull the medical chart for each of the selected patients for review. So here we have a standard form that we have provided a copy of, and as an example in your guideline. And so this is the standard form that you would use for your supervision and your clinical audit. So here is the basic information: the facility name, the district name, date, name of supervisor, name of medical officer who would be at that facility. Has the facility started a hypertension treatment program, or it could be the diabetes program in this case, and you put yes, no, are not applicable. Then you have different sections of the form. So the first section of the form looks at the indicator. So here you look at screening and blood glucose measurement. It looks at, is FINRIS screening done for adults greater than 40 years? And here you would circle any of the yes, no here. And then it looks at other parameters. Is the blood glucose measurement protocol displayed on the wall desk? So it looks at specific aspects of care, and here you would then check whether yes, no, or not applicable. Then it looks at, is there at least one functioning blood pressure monitor in the facility? Are all the patients with HbA1c greater than 9% referred to, and this would be country specific as to where you would refer on persons with a high HbA1c for further management. Are all patients with diabetes and blood pressure greater than 130/80 referred to the primary care physician for treatment? And so again, these are all specific parameters with respect to the standard of care that we are measuring. You can also, for how many patients was blood glucose measured correctly? So now in this, you would then observe 5 patients and looking at greater than 2 of each staff. So you look at about two staff members. How are they measuring that blood glucose? And then you would rate at similarly for blood pressure. So this is now really looking at how the care is delivered. Then you have the other section, which is looking at treatment. So is the treatment algorithm displayed on the wall or desk? For persons to be able to see who the doctors who are treating the patients. And then the next section, you would randomly audit about 10 patient treatment cards. And this may be higher depending on the number of patients that you have and how the number of patients that you decide to randomly select. And you write for that proportion of patients, then you go on to look at the treatment. You look at the blood glucose and blood pressure was recorded at every visit. for the last 3 visits. And so this is now looking directly at the records to see what has been captured and documented in the clinical records. And this, my experience, very, very important to look at this. This is where a lot of audits of health facilities fall down because there's not good documentation. You can also look at medication was intensified or added as per protocol. HbA1c was greater than 9%. Again, so you're looking at what sort of care was delivered and how was that care delivered based on what was documented in the record itself. Cardiovascular disease risk assessment was done for patients with diabetes and HbA1c greater than 9%. And so you're looking at the yes, no, was that done? You're also looking at aspirin was given if patient had prior cardiovascular disease. You write not applicable, if not applicable in this state, if the patient should have had it, yes or no. Statin was given if patient was greater than 40 years with diabetes or if the patient had prior cardiovascular disease. Referral to a specialist was made if HbA1c was greater than 9% after treating with metformin and insulin. So not applicable if not applicable. And then HbA1c was a target for patient classification at last visit. So this is through the docket review, looking at what was documented. And so if it wasn't documented, then we need to make a record of this. But this is where I found, based on my experience, that a lot of health facilities fall down in terms of documenting what treatment was delivered and the standard of care. So, and the next area is looking at counseling and follow-up. And similarly, this is a yes, no, are not applicable. So it looks at, is there staff assigned for patient counseling again? It looks at systems for counseling and systems for follow-up of defaulters, patient reminders. So all of these are really, again, assessing parameters of care. The next major area is service delivery. And this is where you interview 5 patients and validate the information that's found there. So you're looking at, was glucose measurement measured at every visit? The blood pressure. Did the patient receive prescribed medications at this visit? So this is a very critical component. So in addition to your observations, in addition to the records, how is it on the patient aspect? How do they perceive care, or what sort of care do they confirm has been delivered at this health facility? And what we've done is provided you with a tool also to interview these patients. And so these are 5 patients that you would interview, and for each row here, you would now be able to ask these 5 questions. Did the patient receive all the prescribed medicines? It looks at patient having to pay for medicines, understanding of how to take the medicines. Do they know whether the blood pressure was under control at last visit? This is something that should have been articulated or discussed with them by their doctor. Does the patient know the target blood pressure? So you get another patient perspective as to the delivery of the quality of care. So again, here is also this tool that the summary at the end of your clinical audit. Now, you can summarize this information, looking at the key problems identified in the heading areas and then the recommendation. So once you put this summary together, then you can leave this with the healthcare team so that they can address these problems. And then on your next follow-up visit, you can look at whether these problems have been addressed or not. And in your supervisory and audit visit, you should let the team know ahead of time. You should meet with the team prior to this clinical audit to explain to them the process. And after you've finished the clinical audit, you should meet with the team again in order to provide adequate feedback from the audit so that they can also use this information to improve. And in addition to this summary, you should also highlight some of the good practices that the team has implemented in delivering the quality of care. So that would be couple the system in terms of what the guideline covers in terms of monitoring the delivery of care and the implementation of your clinical guidelines within a clinical setting. And so that is critical. So I'd like to just highlight now, looking at COVID-19 in the context of systems monitoring. So as we all are aware, we've been going through for over a year responding to the COVID-19 pandemic. And one of the things that we would want to also seek to look at is we know we've been implementing the COVID-19 public health measures. And so there's a possibility of disruption of the health services. And there have been studies that have been done within our region to show that many of our health services have been disrupted, especially around screening and some of those outreach programs. So we really want to also look at tracking this information as well. And we should also consider collecting data around COVID-19 vaccination coverage within persons with diabetes. And we should also be looking at tracking COVID-19 patients, looking at the proportion of those patients who have diabetes and the mortality rate. And these are important parameters to really look at the impact of the COVID-19 pandemic on diabetes itself, both the delivery of care and also on the impact on the outcome for persons with diabetes. As we know, it's well established that diabetes is a high risk for severe illness and death from COVID-19. And so these are some of the things that parameters we'd want to track. So I'd like to share with you that the World Health Organization has actually put out a publication, which I'd recommend we look at, looking at analyzing and using routine data to monitor effects of COVID-19 on essential health services. And so provision of services for persons with NCDs, including diabetes, is part of essential health services. And so this is a useful tool just to look back and to ensure that we are integrating any surveillance of COVID-19. We're also integrating in there monitoring as well of diabetes, delivery of clinical care, and also the impact on persons with diabetes. So my take-home point is that systems monitoring is an important component of the implementation of any clinical guidelines. So monitoring and evaluation should be not left till after somewhere down the line or something that we don't give priority to. Monitoring any program and evaluation as well is a critical component in knowing where we are with respect to the progress towards achieving the program objectives and targets, and ensuring that we deliver high standard of care to our patients. And so part of that is a continuous part of loop of monitoring, evaluating, and that feedback loop to working with our teams, and also celebrating some of our successes with respect to providing this care. And it should be tailored to the national context. And this would be national at a country level, and also within country, there may be contexts where we need to adapt it to the district or health facility level. But most importantly, the journey, we should start that journey, and that journey is a team-based approach. And this is not a start and stop, it's a journey that we'll need to continue and an ongoing process. But it's important that we monitor what we do so that we know where we need to improve, and we can reward success where success is in place. But most importantly, we're doing this to ensure that we have a healthy and robust population, that everyone, whether or not you have an NCD like diabetes, we can live a full and productive life. Thank you.
Thank you, Dr. Davidson, for that very well-rounded presentation. And while we give Dr. Davidson a quick breather before we start our Q&A session, I'd like to go through the key points that she touched on as a quick review. We know how important review is to learning. So Dr. Davidson looks at the definitions of monitoring, evaluation, and indicators. We looked at indicators as a foundation for measuring performance. And we know that measuring performance is not only about being the police or the person with the ruler standing above patients. It's about ensuring that what we set out to do is actually what we are working towards. As we know, the saying, if we don't measure it, it's not done in some cases. We looked at indicators, core indicators or recommended indicators for NCD programs. We looked at 5 for health service coverage for NCDs. We looked at 2 for health screening and preventative care, as well as 2 for the access to essential medicines. And these indicators can be found in the 5th module using the link that would have been shared in the chat. And as Dr. Davidson said, these are some recommended and core indicators, but of course, we may also wish to have our own indicators at national or subnational levels based on our actual context or needs. We looked at the importance and the use of indicator reference sheets, and these are sheets and tools that present metadata about indicators, and these help us ensure that we have a standard method of collecting and measuring data for indicator reporting. We want to ensure that data is comparable both within our own context as well as when we want to compare it across districts or subnational or facility levels. And we know the importance, the saying of that garbage in and garbage out. So we want to ensure that when we have data to report on indicators, they are to the highest quality. We looked at the models of record keeping. We know that a lot of facilities and regions still use paper-based record keeping, and they are quite efficient where we can use them. We looked at electronic and hybrid, or both paper and digital record keeping, and where these can be best used. Another topic that Dr. Davidson discussed or touched on was data sources and tools for collecting data that we can then use for reporting. An example is the facility outpatient register. We also looked at the importance of supervision and clinical audits using a whole of care team approach, and of course, ensuring the confidentiality of patient information. We reviewed an example of an audit tool, which again is also included in Module 5. And we looked at how sample sizes can be determined for those of us who are not particularly mathematics based. So I'm sure that will help a lot of us. We looked at systems monitoring in a COVID-19 context and shared in the chat a key resource from the WHO, the World Health Organization. And of course, we want to emphasize at the end of the day that we're measuring progress towards achieving our particular program objectives, ensuring high standard of care, and we want to always tailor our monitoring and evaluation programs to our national, subnational, or facility context. So at this point, again, I'd like to thank Dr. Davidson, and we will go to the chat on our Q&A sessions to see if we have any questions. So Dr. Davidson, I'm seeing a question here. Although she said that her question was answered, we can still review what she said. So she said, how is the data analysis homogenized in terms of the analytical tools used and reporting structure? I mentioned this so that reporting national and internationally data are also standardized. And of course, we mentioned, well, I will let you go ahead and review that part of the presentation.
Yeah. So most importantly, we mentioned that you would select your indicator, and of course you have to have your reference sheet or your metadata that would tell you how the indicator is calculated, what's in the numerator, the denominator. You have this so that you can standardize indicators, so whatever health facility that's reporting on that indicator would be reporting on the same thing. So that's important. That analysis then is done because we have this information. It tells you how the indicator is analyzed. Now, the indicators that we have selected are indicators that are used in many different areas. Again, as mentioned, it should be based on the needs at the local context. So if you think about it, at your health facility, if you're looking at a pyramid, that would be the base. And at the health facility, you're collecting lots of data, different data that you may want at your local level, and then you have at the district level, and then you have at the national level. And so going up and less data. And of course, at CARPHA level, we have selected just a few core indicators that we would need to track. And so that data now, once you have the indicator and how you're going to analyze it, that provides you with that basic information. What we have done, which I in the guidelines, so you can refer back, so I invite you again to look back at the guideline. In the guideline, it outlines for each indicator we have recommended how you calculate that indicator, why the indicator is utilized, and what use it has. And also for setting targets as well, you will have to do that at a local level. What I've shared in the presentation is that the global general target there is that we want to reduce premature mortality due to NCDs. And so if you go back, in order to reduce mortality, you need to improve the standard of care for those persons who have the existing disease. For example, we're talking about diabetes today, NCDs. And so if you improve the standard of care, then you can reduce the likelihood of complications and also death. And also the guideline provides an opportunity for screening. So you want to track screening of persons so you can detect the disease early in order to put in the necessary treatment and management interventions. As a part of that process, we do clinical audits and we capture data to track that process. But in terms of analyzing the data, the guideline provides you with a full detail for each indicator, how it's calculated, and how to actually analyze that indicator. Thank you.
Thank you for that response, Dr. Davidson. And looking in our chat, I'm not seeing any further questions, but I do think that we can have a conversation. We have a little less than 30 minutes to discuss what we looked at today, what you presented today. And I want to ask perhaps if you want to share with us your experience of participating in a clinical audit. What was one key challenge or one key lesson learned? And perhaps we can get our participants also to respond to that.
Yes. So in carrying out or participating in the audit, what we found consistently was that, and we also interviewed both patients and both did observations and audit reviews. So we found that in reviewing the audit, doing audits, things like blood pressure was always documented, but things like height and weight in order to calculate the body mass index wasn't always there. Also, when you went to the record, there wasn't necessarily good documentation. That was always a gap of what the treatment that was offered. More likely, the most common thing was medication that was always there. But in terms of what the findings were, in terms of testing, the standard tests that need to be done by a person with diabetes, there wasn't much record documentation of that. Very often, persons were not documenting referrals, and very often persons were not getting referred to referrals as in keeping with the guideline. So documentation was a huge issue. So it may have been done, the patient may have gotten that referral, may have been asked to do certain tests, the test results may have come back, but documentation was a gap. Another thing is there's a gap also in the utilization of the guidelines many times because of the high turnover of persons. They may not have been aware of what the guidelines required of them. And so the importance of having that at the health facility, refresher, orientation of new personnel that come on board, so they're aware of where to find the standards of care and what the standards of care are for that particular condition. So documentation and doing routine tests that was an issue. Ensuring, for example, like an HbA1c was done for persons routinely in keeping with the protocol. And some of these had to do with also access issues. So in implementing a guideline as well, you have to then look to what are some of the resources that need to be in place to support implementation of the guideline. So if our guideline says that we are required to do HbA1c, is it available or accessible to our patients in the local context? And so we need to put in that sort of support. Blood pressure machines, as basic as it may seem, but in our context in the Caribbean, we're seeing a high volume of patients on a daily basis in our health facility. So that equipment may need to be replaced on a regular basis. And so we need to have functioning equipment in place. So in addition to implementing the guidelines, you need to ensure you have the requisite infrastructure in place to do that as well. The other challenge was that with the patient side, intervening patients, they really wanted a one-stop shop. So when you do not have the medications right there at the health facility, it means that they have to go elsewhere. It also means if they don't have all the medication they require, they may have to go privately. And of course, that can affect whether or not they're able to take that medication on that end. Most of the time, patients were happy in general with the care of persons, but those were some of the gaps there. The also gap we found was also that patients, whilst they knew some of the things they should do, they lacked an understanding about their disease itself. So, what is diabetes? How do you get it? What does it do to your body? And I think that that's a very critical component in ensuring compliance with the treatment as prescribed by the physician on that end. So, also testing as well. So the patients may have been referred for testing. So leaving, usually a person with diabetes will visit about 4 times for the year routinely if they don't have problems in between. That's usually the standard. And sometimes they have to go travel quite a distance to get the test done, and then the results have to come back to that health facility. So having testing available, even basics such as HbA1c testing on site, would be useful, or useful at least to have on site the ability to collect the different blood samples, because it's not only HbA1c, they'll have to do their blood chemistry, other tests on site, being able to do the bloodletting, so taking the sample, and then so that the patient doesn't have to now travel, in addition to coming to your health facility, then have to travel to another facility, which is another additional cost for the patient. Having the medications available on the routine standard clinic days is important. One of the things we also found with auditing is that it's also good to concentrate special days for seeing persons with chronic illness, because they're interfacing with the health system for a lifetime. So having special days for seeing those patients and then concentrating some of the services on that day is important. So part of the care includes the nutritional counseling, and sometimes that's not available on the same day. So that the patient, when they come in, they're able to see the different team members on that particular day. So as best as possible, we should look at how we can streamline some of that. And some of that is the real challenge, is because of the resources in many of our Caribbean countries. We do not have all the resources there. And so we need to look at our team members and how we can train up to support some of these different elements. So the guidelines we have presented over the past, since last year, the 5 modules deal with different components, including the healthy lifestyle support, etc. So in doing the audits, documentation is a major gap in record keeping. and also remind us about the standards of care because we have new doctors in place. And for patients, their lack of knowledge around their disease itself and a lack of understanding, and also the issue of access to medicines. So ensuring that that's available and testing the one-stop shop approach is what a lot of patients desire.
And thanks for that really good overview of findings that you may have seen across the board in your past audits. I liked that you mentioned in particular the treatment or the lack of documentation of particular treatments, because we know that the treatment pillar in the cascade of care is very important, and we cannot see if we are reaching our goal at the end of that cascade in terms of persons who may have their diabetes under control without knowing what treatments they was prescribed, if there had to be a change of treatments, etc. I'm seeing another comment in the chat, and it reads, an issue I have experienced is a patient not reaching a goal that is established. For example, a decreased HbA1c, while clinical team was following the guidelines, and this can sometimes affect a clinic's overall score. Do you have any thoughts on this?
Yes, so remember that a guideline is just a guide, it's a minimum care. And so if you have challenging patients where you're not getting the HbA1c down, then that patient may need to be referred for other care. However, in my practice, I found usually when you're not achieving that goal, there's something that you need to go back and re-interview and re-interrogate the patients. Very often, sometimes they're not taking the medication as prescribed or their nutrition component. And so when we talk about treatment in diabetes, we're not just talking about the medicines, we're talking about treatment using physical activity, treatment using so exercise prescription, your nutrition component. So if you're not adhering to these three, then you're not going to get good management. It also means that the patient may need to be referred on. But the guideline provides you with a minimum of care. You must treat the patient who is in front of you. And so you may need to go beyond the minimum of care that the guideline provides you with.
Yes, and we see, of course, the importance of the whole team approach, because as you're saying, sometimes you need to address the nutrition, sometimes you need to address the psychological and the social counseling and support from caregivers and family. Another comment in the chat reads, a challenge I have seen is specialists treating with medications that are not on the family list of the primary care clinic that the patient usually visits. This leads to a seesaw in medications if the patient cannot afford these medications prescribed outside of the primary care. Another comment says specialist treatment does not necessarily match with general practice treatment. Any comment on this, Dr. Davidson?
Yes, that is true. That is true. That does happen. Provider preference in terms of prescribing practices. One of the ways that I've really tackled this, or been a part of a team that we have tackled this, teams have tackled this, is really, again, orientation and sensitization of providers. Very often the pharmacist will provide a list of available drugs. And this is why it's important, a team approach and your review. So in your review, this would be discussed, well, these are the drugs that are provided, that are available, and these are the basic ones with respect to the guidelines. It may mean, however, that you may need to have these additional drugs that specialists may be prescribing. So each country should have in place what we call the VEN list, the very necessary and essential drug list, which will provide you with the minimum drugs, the types of drugs that should be available in your health facility. So it guides that. So it's not driven by individual preferences. You know, I might prefer a really expensive drug. And the main aim is that we really should try to prescribe medication that is available in our health setting. There may be instances, and not in a large cases, where patients may need drugs that are not within our health system. But the medications that are provided should be guided by this VEN list, It should be reviewed periodically. It should have everyone's input into it, including specialist input. But meeting as a team and discussing this, orientating persons, having the pharmacist send a list of drugs that are available in the setting, so that including the specialists and the physicians in primary care are aware of what is available, so that their prescribing practices around that. But it's not an easy fix, and it's a constant dialogue amongst the different team members.
And the follow-up comment says, I understand, but when the specialist works outside of the government health system, they prescribe other medications outside of the primary care facility pharmacy. And I think this is the case in many Caribbean countries. Yeah, agreed?
that does happen. Again, it's going to take dialogue and holding persons to this standard of care, sharing the information around standard of care. And of course, every physician is treating the patient they have in front of them. And and they may prescribe, yes, outside of the system, medications that are not in the system. And the main aim is to ensure that the patient has medication that's accessible and affordable to them. And so you may have to change and adjust. But one of the things that we should do is engage at specialists to explain, to have that dialogue. Because very often, sometimes we do not recognize the social component of providing clinical care. And so if we prescribe something that the patient cannot afford, they'll not take it. And so they'll not improve. But
Yes.
it will take one-on-one dialogue and reaching out to that specialist and that clinician to have a discussion about the patient management and how can we adjust it so that we have this medication that the patient can access. But sometimes the formula may need to be updated with respect to the current availability of medication. But I would encourage dialogue all the time. It's not a one fix, and this is the challenge that we have, that ongoing. And I've heard myself, I've had that challenge, and colleagues who are much, much older and who have been in the system. But we should try and engage physician to physician discussion around the management of the patient.
And while we continue the discussion, I'd like to ask our webinar team to put up the post-session poll, and we can answer while the discussion continues. So, Dr. Davidson, there's another comment in the chat. It's also important to note that the HbA1c can be altered according to underlying conditions, which can cause misleading HbA1cs, and particularly within the COVID-19 environment. What would you have to say about that?
Yes, so HbA1c continues to be the standard, but we do, along with the HbA1c, you also would want to track the fasting blood glucose, and you also want to do a 2-hour for that patient. So it's interpreted in that context, but certainly HbA1c is still the standard, and yes, it could be altered, but you're managing the patient who is in front of you, and so it's important to look at that individual patient and all the parameters, including these tests, with respect to assessing that particular patient. So HbA1c is still very, very important. It's a standard, but we use it along with your fasting blood glucose, your 2-hour PP. You could also get the average blood glucose in some contexts. But you have to look at what the resources you have that are available locally in terms of doing this interpretation. But yes, it's possible, but you have to look at it in context with other blood investigations that you would do with your patient. Certainly, the random blood glucose is not recommended as a routine tracking of your patient's control. Certainly, you would do HbA1c and the fasting and 2-hour. In my practice setting, I would also do the 2-hour PP as well, along with looking at the HbA1c.
Great. And perhaps we can refer to the resources that we have on our website at this point. We
Yes.
have the 5 full modules of the guidelines available for your review and download. We also have posters of the 3 algorithms. Maybe Dr. Davidson would like to speak with those. I think we have them for screening, for treatment,
Yes.
and another one, if you can remember.
For the management, using insulin management.
Right.
So we do have 3 algorithms. So I refer you back to the guidelines. I just want to emphasize a guideline is a basic minimum standard of care. You must treat the patient who is in front of you, but it is a minimum standard of care that everyone should meet. You may go beyond that minimum standard of care, but the guideline provides you with the minimum standard of care that you should be delivering to your patient in this context. But please treat the patient in front of you.
Of course. I'd like to ask the webinar team to put up the QR code if that is available. So in addition to the polls, we do have an evaluation form that is available should you wish to give us any further feedback in terms of what this session has provided for you and what you'd like to see from us in the future. As you may know, we are rolling out these guidelines through a variety of initiatives. So this webinar series was one of these initiatives. Dr. Davidson may also wants to speak to in terms of the printing. We will provide printed copies, a certain number per country, and you can go further and let us know what else we can expect.
Yes, so we will be providing printed copies, and also as a follow-up to these webinars, we will be training resource persons within the countries to be able to do further training in country around this guideline in the context of your own national guideline where it does exist, and to disseminate this information. But I'd like to encourage you, even if you have not done modules 1 through 4. The recordings are available online, so I'll encourage you to view those recordings. And so for this year, we expect to have copies of these guidelines, limited copies. The posters may also be adopted or adapted in your respective countries, in your organization. Some of you may not be working within the context of Ministry of Health, but in private sector or civil society. We'd like to adapt these posters. You can just contact us, and we will share it in a format that is adaptable for you. So we have quite a bit of resources. We also look forward to a new guideline for hypertension, which is on the horizon as well, through this project support.
Thank you for that. So again, I encourage you to check our website, check our social media. I think we will share these in the chat, and keep following us to find out more about these guidelines and what further initiatives we have. So as Dr. Davidson mentioned, in addition to the posters that will be printed and some of the printed copies of these modules, we will also be looking at providing pocket guidelines, etc., for ease of reference at clinical or other discussions that you may wish to use it. And at this point, we are coming to wrap up this session. So thank you for staying with us. And I'd like to thank especially Dr. Davidson for reviewing the key information from Module 5 of these guidelines on the management of diabetes in primary care. On the screen, we have shared the poll results. If you have not completed the poll, please do so now, or I don't know if it's closed, but you can take a look at what the general consensus is for each question. So these guidelines continue to be critical tools for clinical teams, whether public or private sector, as well as good references for patients, their caregivers in the Caribbean region to support our evolving needs and provide recommendations for updated evidence-based treatment and care. And so we continue to work towards improved health outcomes at the patient level, at the facility, subnational, national, and regional levels. And so please do continue to engage with us and interact with us. Shoot us an email, send us a message on Facebook if you have any particular needs. And really, thank you for staying with us through this webinar series. Please feel free to go to our YouTube channel and review the recordings. Thank you for engaging with us and your questions and your comments. And I'd like to wish all of you please continue to stay safe and well as we work towards CARPHA's vision, which is healthy people, healthy spaces, and a healthy Caribbean. Thank you. Dr. Davidson, any final comments?
So at this point, I would like to encourage everyone to visit our website, really to go through the material and to utilize this in your context towards really improving care. The countries in the Caribbean, our people rely on us to deliver the highest possible quality of care. And the Caribbean has always had a high standard of excellence in the delivery of our health program. So I'd like to thank everyone who continues to commit themselves to delivering this high standard of care. We are stronger together as a region. So let's work together, share our experiences, and I would say walk good and happy Easter.
Thank you, Dr. Davidson, and thank you everyone for staying with us. You are welcome to send any further messages you may have to our email addresses that will be available either via our Facebook platform or YouTube. Do feel free to reach out to Dr. Davidson and the team or CARPHA in general. So thank you again, and we look forward to a happy Easter for all those who celebrate Easter and a little vacation for those who may have school-age children. So thanks again and goodbye.
Bye, everyone. Thank you.